Good evening, and thank you for joining this webinar. My name is Carol Michael, and I'm truly honored to be here. I must admit that it's both difficult to know where to begin and easy to support the very special global palliative care program at Mass General. Like many others, my introduction to palliative care was personal. It began 14 years ago when my late husband was cared for at MGH. At that time, we thought that choosing palliative care meant no more treatment, the end. What I learned was that it was the opposite. It meant the best of care, treatment that research shows can provide more life and a better quality of life as one deals with serious illness. My learning continued as I participated in the ongoing palliative care education at MGH. I was asked to share my insights and perspective as a family member by physicians, nurses, social workers, administrators. It enabled me to hold both the terrible sadness of my loss with the gift that I was able to help teach others to make a difference with more patients and their families. I then had the great good fortune to meet Dr. Mark Stoltenberg and Dr. Bethany Rose Dobman, the MGH Global Palliative Care co-directors. I traveled to Chile with them and Dr. Vicki Jackson to be part of the wonderful program led by Dr. Pedro Perez Cruz. Their ability to respect and honor and integrate the healing and wisdom of cultures that had been sidelined in the march toward modernity and combine that with the knowledge of today's medicine is truly awesome to witness. Welcomed into this incredible circle, I experienced firsthand the inspirational impact their work has on the lives of patients and families and communities around the world. These are the wonderful people that tip the universe toward goodness, a direction we desperately need today and whom we can support wholeheartedly. A bit of tech administrivia now. During this webinar, please feel free to submit questions with your name or anonymously if you prefer. Following Dr. Stoltenberg's and Dr. Dobman's presentation, there will be a Q&A session. Dr. Vicki Jackson, Chief for the Mass General Division of Palliative Care and Geriatric Medicine, will facilitate. And now it's my pleasure to introduce tonight's first speaker, Mass General Palliative Care Program Co-Director, Dr. Mark Stoltenberg.
Carol, thank you so much for that incredibly kind and generous introduction. It's been such an honor partnering with you. We're excited to continue in that partnership together. And welcome to everyone that's joining us this evening. So I'm very excited to take a little time and describe for all of you a little bit more about the MGH Global Palliative Care Program. So I think an important place to start is to just name what is the current context of access to basic palliative care around the world. Some of these statistics might not be a surprise to all, but I think it's important to note. So of the 58 million people who die each year, 45 million die in low and middle income countries. And currently, in the vast majority of those cases, palliative care access is minimal in most low and middle income countries around the world. This is one graphic that was created from the Lancet Commission back in 2017 as a way to illustrate what that current access gap is. And so this is showing the total oral morphine equivalents per patient through their entire course of an illness that they have on average. So a way to think about this is a patient with cancer in a place like Uganda or India, on average has 53 milligrams of morphine, not per day, not per month, but for their entire course, which could be years long with their serious illness. So what this means is the vast majority of patients don't have any access to any opioids and are experiencing their serious illness with immense suffering and ultimately dying in pain and other symptoms that they're experiencing that are not well controlled. It can be helpful to name the problem with data, and I think it's also really important to name what this actually looks like. So I had the honor of starting to partner with leaders in Belize back around 10 years ago, and this was a hospital on the southern part of Belize. And I was working with the founder of palliative care in Belize, who's an anesthesiologist and is doing her best to grow palliative care across the country. But at this time, there hadn't been any trainings. There was very little access to any opioids for patients. And I met a patient with stage 4 lung cancer sitting in his room that didn't have a window. The family weren't sure, the clinicians weren't sure that you could use opioids safely to be able to manage his dyspnea. There wasn't a social worker to talk about where his family was and how he was processing what was going to happen next. And ultimately, he was in that room for 2 weeks before he finally died alone, in pain and short of breath. There are many good people in Belize trying to make this better, but that is what the reality is in these corners of the world where there still is not access to basic palliative care. So there's good news though. So some things have changed over the last 10 or 20 years, and it's part of what set up our MGH Global Palliative Care Program to start trying to make a difference together with a lot of other partners around the world. So one thing that's changed is the evidence base for palliative care has grown substantially over the last 10, 15, and 20 years. We now know this was one of the hallmark studies that was done at Mass General Hospital with Dr. Jackson was a part of that study team back in 2010. Showing that if we integrate palliative care from the point of diagnosis, we know that it improves overall outcomes for patients. It improves quality of life, decreases suffering, things like physical symptoms, but also other psychological symptoms, and ultimately, in this particular case, actually led to patients living longer. This has been repeated in many other studies, and we know palliative care, when integrated well early in the course of a diagnosis, can improve patient outcomes. Added to this, there's also been a growing body of evidence that shows if we meaningfully integrate palliative care, it actually decreases overall healthcare costs. So with this evidence was then applied to the global context with the Lancet Commission back in 2017. This was a two-part piece where they wanted to evaluate what was the overall burden of suffering in low and middle income countries around the world. And then the key piece is they worked with economists to estimate if we integrated basic palliative care services at a national level in either a low income, low middle income, or middle income country, how much would it actually cost? And you can see highlighted in yellow, in low, middle, and middle income countries, we're talking about less than half of 1% of healthcare expenditures for the Ministry of Health for that year. In a low income country, a little more at 3%, but still a very feasible amount of money in 1 year that we now have evidence improves patient outcomes and over time actually decreases overall healthcare costs. So again, I'll pause, and that is the data behind why we're doing the work. But again, I think it's important to share a story. So I had the wonderful opportunity to teach palliative care and also provide palliative care together with other clinicians in Kenya for 3 months and also in Rwanda for 3 months. And during that time, it's hard to say that there were 5 or 6 different patients I saw that were pediatric cases between the ages of 5 and 15 with horrible, horrible sarcomas. So large cancers in their bones. All of them were in the legs that I had seen. These patients would come to the hospital. They had never had a single dose of morphine in their entire disease course. And their parents would come to the hospital and say, "We have not seen them smile in months." They would come into the hospital. We worked with the teams. We were training people on how to use low doses of morphine to be able to manage cancer pain. And the very next day, there was a smile on these children's faces. When we know we have the evidence that things that cost pennies can bring smile to a child's face after just a few doses, it's very clear if we have this evidence, there is no excuse that there is a child suffering in any corner of this world that we could fix this easily and bring a smile on their face. Very clearly, these are not patients of mine. I didn't want to share their photos. These are my 2 oldest children. But I think the smile of a child is something that is absolutely universal, and I think it helps drive home that point. So because of this growing evidence, I think it's also really important to note that the WHO has actually come out and stated that access to basic palliative care is a human right. And they went beyond that and named that it is actually an ethical responsibility and a mandate for all healthcare systems around the world to provide basic access to palliative care, which was a really important movement in the global movement to make sure that we're closing this gap and that patients can have access to this care. So I wanted to share where we're at because there still is a really big gap. But the part that's really exciting, and I'm excited to share one of my partners here in a moment, is that we actually have seen the opportunity for progress has never been better. There are examples and programs all over the world, many which we've been able to partner with, that with really, really foresight of leaders, partnering with at a national level with ministries of health in places like Costa Rica, in places like Chile, and also in Uganda and parts of India and Kerala, India, this can truly be reversed and improved in a matter of years. So yes, the gap is large, but we have the know-how and there are people that have shown us this can be done. So that's then where we hope that our Mass General Global Palliative Care program enters in. It's been one of the honors of my career to partner with my colleague, who you'll hear from in a moment, Dr. B.R. Dobman. And what we are seeking to do, and very much thanks to the support of Dr. Vicky Jackson, who you'll also meet, is to foster, as you can see in our mission and vision here, bi-directional collaborative partnerships to find people that are committed to bringing palliative care to the corners of their world where they live and they practice and they know the cultures, and bring the resources and the experience and things that we have at Mass General and we have in our global palliative care program to help them be as successful as possible so we can continue to grow as quickly and as exponentially as possible so we can close this gap so no one has to suffer unnecessarily. It's been wonderful to be able to partner all over the world. I wish we could highlight all of our wonderful partners tonight, but we're really going to focus on two. I'll introduce my colleague. I'm actually in Chile right now, and we'll talk a little bit about that partnership. And then I'll pass it over to Dr. Dobman to talk about our wonderful partnership in South Dakota. So very briefly, I'm going to embarrass my friend before I pass it over to him. We've been partnering with Chile and with Dr. Pedro Perez and his palliative care team since 2016. I will say I've worked with a lot of people across Latin America. This is truly one of the most remarkable palliative care teams of all of Latin America. They are international leaders in education, in research, and also clinical care. So we started partnering back in 2016 to find where could we partner together, bring some of the resources, the mentorship, and the guidance of people like Dr. Jackson to continue to expand the impact and see if there was a way to create a hub here that could help not just in Chile, but in the rest of Latin America. And through that partnership, there's been a number of accomplishments that we're really proud of. We created a communication course initially back in 2018, then created a basic diploma course that continues to this day that trains interdisciplinary colleagues all across Chile. And then the real sort of our piece that we're the most proud of is we created an advanced palliative care course that was initially modeled off of a course that's Harvard, but we've now thoroughly adapted to Latin America that we teach for a week in the fall and the week in the spring every year. We're excited to say we're in the 4th year of teaching that course. It has now expanded to this year. We had 140 applicants for that course. We have 26 people that are taking it right now that we're 3 days into the 5 days of the first week, coming from 9 countries across Latin America. And we were incredibly grateful that through partnerships with philanthropy, there were 5 scholars that we were able to bring from lower income and lower resource parts of Latin America where the access to palliative care is the least, so that they would be able to take the course. Here's a photo of the 5 that we were able to support this year, which was in addition to the 3 we had last year and the one before it. So we are just so excited how this has continued to grow. It's been one of my favorite parts and the things I'm the most proud of in my career. And now I'm really, really excited that you can meet our wonderful partner that we've been working with through all of this, Dr. Pedro Perez.
Thank you, Mark. Well, my name is Pedro Perez Cruz, and I'm an associate professor in palliative medicine at Catholic University here in Santiago, Chile. And we have been partnering with Mark, Vicky, BR, and the Mass General Global Palliative Care Program for the last 8 years. They have helped our team during the last 8 years in so many different ways. They initially provided training for our clinicians to improve our clinical skills. They have also helped us to acquire teaching skills. And finally, also, they helped us to develop and design 2 different palliative care courses to expand the knowledge to a larger community here in Chile and in our region. When we jointly developed this program, and after 4 versions, the version that we're currently running, we increased the number of students participating from 13 to 26 students from 9 different countries today. And one of the things that really makes me proud and confirms that this partnership has had a huge impact is to watch my colleagues, who were the first students in this collaboration program, become now the teachers of this course. And also to watch alumni of this course taking leadership positions throughout Latin America. So what the Mass General Global Palliative Care Program aims to achieve really contributes to make a significant and real impact in the lives of many clinicians and patients, and not only locally in Chile, but also regionally.
Thanks, Pedro. So I hope what this highlights for all of you, and the last point that I want to make before I pass over to Dr. Dobman, is that we really are in a new phase of development for global palliative care. For the prior 10, 20 years, what we really needed was to create the models. What is palliative care? How do we measure it? How can it best help patients? How do we implement it across the system? We certainly need to continue researching that. There are always ways to improve, but we have good models for how to implement basic palliative care. So where we're at now, it is time to grow and implement. We need to scale exponentially so that we can close the gap as quickly as possible, so there is not a child or grandmother in this world that is suffering unnecessarily that we can fix with basic tools that we know what they are and they know how they work. So we're excited to share this work with you. We look forward to partnering with any of you that might be interested in joining. And with that, I will pass over to Dr. B.R. Dobman.
Thank you so much, Dr. Stoltenberg, and Carol, thank you so much for highlighting our work and being present. We're so grateful for all of you for giving us the opportunity to share a little bit more. This may seem like an odd choice, but I'm going to actually share about our only partnership that exists within the US. But as a team, our global palliative care program really defines the word global inclusively, that it just means everyone, everywhere, every time really deserves access to culturally responsive palliative care. For the past 5 or 6 years, we've had a partnership with 3 tribal reservations in the Great Plains, and I'd love to share a little bit about the work that our team has been doing. I want to make sure I acknowledge I'm one tiny part of a large tribal academic partnership, and really the people who are doing the bulk of this palliative care work are our community health workers, Paige Fastwell from Maine Tobacco and Caroline Spotted Tail. So I wanted to make sure that I acknowledge all of their incredible work as well as that of our team as well. So this partnership began in a little bit of an unusual way, but MGH has had a rural health partnership for well over a decade with one of these tribal reservations where clinicians actually come from MGH and fly out to South Dakota and make the long trek to this reservation community and provide clinical care in Indian health services there. As you might imagine, there are lots of challenges that exist to accessing healthcare in these reservations. The size of the land, these reservations are large, they're rural, they're often very isolated, and if you want access to any type of specialty care, often that's a 5 or 6 hour drive if the roads are passable. And there are innumerable systemic injustices that many of these patients face. So there's lots of challenges. But whenever our clinicians at MGH asked, what do you want us to focus on? How can we really partner with you in a way that's most meaningful? Inevitably, the answer that these elders would give is we want to be able to be born on our land and die on our land. I'm a little bit rusty on the born part. I haven't delivered a baby in well over a decade, but the dying on our land in a way that felt significant to these individuals, to me, that really struck a chord. And Dr. Jackson was really tapped to be a part of this program and wisely said, I think this is actually global palliative care, and encouraged Mark and I, why don't you go out to these reservation communities and really see what you think? When I went and visited with patients and met the people who are doing this work, really the serious illness-related suffering that I saw and witnessed there rivaled anything I had seen in the low-income countries that we worked with. So it felt very mission central. So I've mentioned some of the challenges that exist in these reservation communities, but our tribal elders have really prompted me to have a strengths-based approach and say, yes, there's lots of challenges. Everybody probably knows about them. Do you know about our strengths as a community? And so I always like to make sure that I'm also emphasizing the incredible family relationships that often exist in these communities, that many of the homes are intergenerational, that when someone is sick or going through a transition, there's an incredible amount of community support. The way that relatives and family members support one another is unlike anything I've ever seen. As you can see in the bottom right, there are also rich traditions of traditional healing practices, and there are often ceremonies and rituals that can be performed when a patient is seriously ill that are bring incredible comfort, support, and strength. There's been times where I've been uncertain and talked to our team and said, is palliative care congruent here? Does this make sense? I know the elders have asked for it, but are we doing the right thing here? It can be hard, as any of you who have experienced serious illness know, to talk about these things, to witness these things. And one of the elders really wisely said to me, listen, BR, Buffalo face the storm. And as it's been described to me, my grandfather is a dairy farmer, so I know very well that cows, when it's bad weather, run into the barn for shelter. But it sounds like in these communities, the buffalo is seen as a sacred animal, and I didn't realize buffalo face into the bad weather and they face it head on. And these communities have told me, we're willing to have these hard conversations in a way that I really haven't seen anywhere else. And it's such a strength to be able to prepare with these communities and have them feel open and willing to share and talk about, as they would put it, passing into the spirit world. So I'm so grateful for those lessons. That being said, it hasn't been an easy or a smooth process necessarily. When I started this work, I had been doing global palliative care for about a decade. And so I thought I was pretty good at least the beginning steps of it. Of course, whenever we're partnering with another country, with another community, of course, we want to be culturally humble, and palliative care looks different and should look different wherever it is. And so there are different aspects of palliative care. How palliative care is translated or interpretive, of course, is always different. And I thought I had a little bit of a framework of how to do that in different communities. But I'll say it took a good year. I tried different language, we tried different analogies, metaphors. Even though the elders were very clear that they wanted access to end-of-life care, we really couldn't figure out a way that was palatable to patients of describing palliative care. And I just kept fumbling through it, and we weren't really advancing in the way that we had hoped. There was a time that one member of our research team was actually moving on to a different job, and our team came together, and the tribal members of the team engaged for her a traditional ceremony, a star quilt ceremony. And as it's been explained to me, this is often a hand-sewn quilt with different colors, have different significance. The patterns are very significant. It is often gifted to someone in times of transition. So it may be a graduation, it may be moving away, but to show the community support. And it's wrapped around this person in a way to say, you're not alone. We are with you. We're acknowledging this transition. And it was just a beautiful ceremony for our team to allow me to be a part of. So I quickly sidled up to one of the elders and said, call me crazy, but should we just say palliative care is a star quilt? It doesn't change the weather. It doesn't change that there's a journey happening, but it's a way of showing that community support and honoring that individual with dignity. And you could see the relief in his eyes of, yes, like, please never again say any of the things you were trying to describe palliative care. We're just going to call it a star quilt. So after a year of trying, we finally got there, and we were able to sort of move ahead in this partnership. And I'm so grateful that I had that one individual and many tribal individuals who were able to really share their wisdom. So certainly palliative care is always a team sport. So always an interdisciplinary team, making sure that we have Native partners who felt incredibly comfortable and empowered, that their wisdom is something we absolutely needed to hear at every stage of the game. And one of the individuals that has been one of our most key partners is a former chief tribal judge in these communities. I've never had a judge or a lawyer as a key member of my research or a clinical team, but in this case, his ability to understand the ethics involved in palliative care, to reach out for community support, to really work with tribal advisory boards has been indispensable. And then every aspect of our work is guided by 3 community advisory boards consisting of enrolled tribal members, of patients, of caregivers, of tribal elders. And very quickly we saw how powerful and impactful traditional healing was. And so we're so grateful that we've had some traditional healers be willing to partner with our team. So it's a big team that I'm so grateful for, and everyone brings different strengths to the table. I'll highlight a little bit more. Even beyond that team, it became very clear early on that I was not the right person to be providing palliative care in the homes, that it really should be care that is provided by members of one's own community. And so we had community health workers that we were partnering with to train in palliative care skills. And again, our tribal elders said, community health worker feels a little sterile. That's not exactly the right language. And one of our elders really helped us develop, using the Lakota language, the word Wowokia. So we call our community health workers Wowokias. And you can see here the translation here, that these are people doing something good, doing something natural, collectively working with the patient and family and accompanying them on their journey. And so again, I never would have been able to come up with that. And I'm so grateful that the language of Wowokia has really resonated with our patients and families. So here's a picture of a few of our Wowokias here. And after they started seeing patients, we were able to really target some of the hard points. You can probably imagine that caring for seriously ill patients within your own reservation community could be challenging on a number of levels. And so we engaged in a 2-day long workshop, a training to really help hopefully advance the skills and provide resiliency and support for our Wowokias. I love PowerPoint. I had hundreds of slides. We had some scenarios we were going to role play as a team so we could workshop the best way to engage in some of these conversations. And our Wowokias were good sports, and we finished the first day. And one of them took me aside at the end of the first day and said, BR, that was great. Thank you so much. Just have a little suggestion. Tomorrow, I think what we don't need is more slides, more learning. I think what we really need to do is to pray for our program. And she said, I'm happy to share with you all how we could do that in a traditional way. And she was so generous and really bold in asking and really sharing her wisdom of really what we needed to do to make this a culturally responsive program. I'm so glad she did. And so, of course, we scrapped all the training we had. We actually took a little team field trip. So this is Bear Butte, a sacred mountain in the Lakota tradition. And so those who were willing and able were able to climb this mountain as a team. And this Wowokia Romaine was able to help us learn and practice tying dried tobacco. And you can see different strips of cloth, which have significance. And whenever we were led to pray as a team member at the summit here, we would tie the tobacco cloth and pray for the team and really honor the team as they were working with these seriously ill patients. So certainly not a traditional part of a palliative care training, but absolutely the right thing we needed to do. And I was so grateful that our Wowokia felt comfortable in advocating for that. And I think it really changed the tone of the rest of the Wowokia's work with patients. So we were able to partner in a closer way after that experience. And it's still really hard. We're asking a lot of these Wowokias and caring for patients in their own communities, because there's such a sense of community, of relatives coming together. Oftentimes the Wowokias would call me and say, BR, I lost 3 mothers today. You might not understand that because they weren't my blood mother, but in our community, I was caring for them as if I was caring for my own mother. And having all of those patients pass into the spirit world, of course, would take a toll on anyone. So I was again so glad that our Wowokia spoke up and said, I think we really need to focus on our own healing as well. So we were able to engage. We were so honored that one of our traditional healers and a social worker who's a member of these tribal communities and had experience with bereavement and traditional healing practices, and were able to come. And I certainly wasn't leading this, but I was happy to just be able to listen in and hear them share their traditional wisdom and help engage our community health workers in some traditional healing practices, including a wiping of the tears ceremony, so that we could feed back into the Wowokias who are doing this beautiful work for our patients and for their families. So that's just a sample of some of the work that our teams have done that we're just so proud to be able to share with all of you. So maybe I will pause there and turn it over to Dr. Jackson and just say thank you so much for listening.
Thank you, Dr. Dobman. I have to say, I am familiar with this work, but every time I hear you present, I am moved. I am so incredibly moved and so proud of the work that you're all doing, and how it's really about partnership and meeting needs in a way that we're learning together. That is just so incredibly, incredibly powerful. So I would like to welcome anyone who would like to ask a question to put one in the Q&A, and we're happy to present those to our panelists. I think while maybe just to kick us off, Dr. Stoltenberg, I'd love to have you comment on, it was really helpful to see the graph looking at morphine use across the globe, and really as that is a key indicator of quality in delivery of palliative care. Are there other hallmark metrics that you and your colleagues use to determine a country's access to palliative care?
Thanks, Dr. Jackson. It's a great question. So we often start with that one because it's one of the easiest to measure. But currently, the WHO now has a new model to think about the development of palliative care in countries. Atlantis is the research group leading it. And ultimately, what it is there's a floor, 2 walls, and a roof. So the floor are laws. So you need public laws and Ministry of Health emphasis to emphasize palliative care. Note that it's going to be something that needs to be implemented in the system. And then the 2 walls, one is access to essential medicines, which that's the easiest to measure, which was the opioids. But the other one is education, because folks need to be actually trained and learn how to prescribe that safely, plus all of the other critical parts of palliative care to deliver it. And then finally, the roof on that house is actually the clinical delivery systems. So you need home-based systems, you need ambulatory systems, you need inpatient and hospital palliative care teams to be able to manage the suffering of patients across all of those things. So great question, and that's in general how we think about measuring it from country to country.
Excellent, thank you. Dr. Dobman, when in thinking about the work that you're doing with the Lakota tribal community, it's fascinating, it's inspiring. And I guess I would love to know, what lessons do you feel like you've learned in that work that could be applied in thinking about work with other underserved communities, either here in Boston or really anywhere else in the globe?
So many lessons learned. I know if my Wobokias were here, they would feel very strongly that there are 326 reservation communities throughout the U.S. Our research has shown, as far as we are aware, there's palliative care being provided on less than a handful of those reservations, and all 326 deserve access to culturally responsive palliative care. And these Wobokias would say, we're not special. They are special, but they would say there are so many marginalized communities throughout the US, throughout the world, throughout Boston that deserve access to care being provided by their community members. And so this model of having lay community members providing care in people's homes who understand these communities, who understand their practices, they feel very strongly that that is the way to provide culturally responsive palliative care. And so I think that's a lesson we're really taking forward to other marginalized communities as well.
Thank you. Dr. Stoltenberg, you talked about having the tools and knowing the effective models of palliative care, and that's really a solvable issue. I think it was really inspiring to think, now we just have to do it. We know, but we have to do it. So what would you prioritize first to help with this scaling and expanding the program's work, really to be able to have an impact, a larger impact, and quickly?
Yeah, it's a great question. So I'm grateful to have had experience in multiple parts of that house, of working with ministries of health to think about policy, of doing training programs, of helping coordinate to build services. But I think by far the biggest impact we can have, the amount of young leaders across Latin America, Africa, and other parts of the world that are deeply dedicated and want to do this work, but they don't have mentors guiding on what to do. They don't have necessarily institutional support. They're not sure how to take their interest and their passion and grow into a program. What we really need is leadership support and training programs so that every person in all of these areas that wants to care for their own community, that has the passion, we can give them the tools via education programs like we have here, but we need another 100 of them to make sure that everyone who wants to dedicate their lives to caring for patients that are suffering and making their life with serious illness a little bit better, that they can get the training and the support they need so that they can be successful. The way I often describe it is there's a lot of little Pedros all over Latin America, and I want every single one to be as successful as Pedro has been. And I think that's where we really need to be putting our attention.
Excellent, thank you. Dr. Dobman, a question from one of our participants who works with Indigenous communities in Australia was wanting to know if you could elaborate on what you've learned from working with this community regarding the meaning they ascribe to death and dying, and how that has informed how you've modified the way you practice palliative care in the community. Like the star quilt, I think we all need star quilts. Like, let's just be clear. I think the whole world needs star quilts for a whole host of reasons. But things that you've learned that have informed other ways in which you've changed your approach to palliative care?
I love that question, and it sounds like there's quite a bit of wisdom of other clinicians who've worked with Indigenous communities. So I would love to connect. Thank you for the question. I think there's so much learning that can be had about end-of-life practices across cultures. And certainly I can't speak for all Indigenous cultures, or certainly I can't speak for Lakota individuals either. But in general, I think a powerful lesson that our team has learned is that there are many misconceptions about lack of trust in these communities, or an unwillingness to talk about death. That if you're at all familiar with, there's a little bit of literature about palliative care in American Indian communities. And in general, the literature sort of, or the common knowledge is you can't say the word death. Don't talk about, they don't like to talk about it. Very clearly, our tribal elders will say, we don't like to talk about it badly. We don't like to talk about it when it's not done in a respectful way, when it's not being a conversation that's a two-way street, when you haven't earned our trust, when you haven't taken the time to learn about our community. So in general, there's this strong misconception that to be culturally appropriate, you shouldn't talk about this, which is actually doing a huge disservice to members of these communities who would like nothing more than to be able to prepare for end of life, to have access to traditional healing practices. But they want the conversation to be done in a way that's respectful, which again is not unique to the communities that I'm partnering with, but I think is probably a common theme throughout many marginalized communities. And I think the language our team often uses is not placing blame on patients of, they don't trust us enough to talk about this, but what have I done to earn this trust? And I think when we take the time to partner and earn trust, I think there's beautiful lessons to be learned about having those conversations in a way that feels respectful, in a way that feels honoring.
Yeah, that's really helpful. I mean, it makes me think that in palliative care, we talk a lot about the importance of curiosity and coming in with an open mind, and really that we don't know until we ask, right?
Mm.
But the importance of not making assumptions in any of these spaces. One question that I have for all three of you, for BR, Mark, and Pedro, it is clear the importance that, the impact that this work is having on clinicians and on patients. I guess, could you speak a little bit about what these partnerships have been like to you personally, and how they've enriched sort of your own clinical practice? And Pedro, I don't want to put you on the spot, but happy.
Yeah.
I just did.
Thank you, Vicky. It has been a really amazing opportunity um, to apply this palliative care approach of curiosity that you just mentioned to our partnership. Like, I felt that when I work with Mark, when I have worked with BR and you, I really felt listened to. And I think that that's something that's not that common when we work like with professionals from different countries. You don't come with the solutions, you just come with the questions, and like trying us to understand better what are the things that we need. I think that has been an amazing opportunity. And in the same way, I think we have learned to trust in ourselves and to also feel that we contribute to the development of the work that you, Mark, and BR do where you work. So I think it's like this bi-directional collaboration that has been a very strong experience. Yeah.
And I think I'll just add to that to add credence to the bi-directional nature of us working together. So I know BR and I talk a lot. One of the most exciting ideas and concepts that has really been career changing for us has been this way of thinking about communication and how it's impacted by both emotions and trust. And in a joint project that started with our colleague in Brazil, we then built further with Pedro and partnered with our colleague who's a leader of palliative care in Jamaica, and said, how does this make sense in different communities? And it has dramatically changed how I communicate with patients every day in Boston, especially when they come from other cultures and other backgrounds that I might not know about. Need to apply curiosity, but it's things I now layer on top that I learned from Pedro, I learned from Danielle in Brazil, that has really made me a better communicator, thanks to the lessons that I've learned from these partnerships.
That's great. BR, other reflections you have?
I think that the curiosity that you so actively mentioned, Vicky, is really the big thing for us. And I think that's why I hope it comes through how passionate we are about this work. That to me, it's so fascinating to be able to partner with people like Pedro, um, little Pedros and big Pedros. We're so fortunate to be able to be in Pedro's home. I'm jealous that Mark is there right now, and to really break bread together and think through problems together and realize that, as he said, we don't have any of the answers, but we do have tools, and we are curious, and we do have a desire to really partner together. To me, that's been one of the most rewarding aspects of this work. And then, as Mark said, it does feel bidirectional. That I think the training and the teaching and the care I provide to patients at Mass General is vastly improved because of this work that we do with our partners. We were very lucky to be able to bring Pedro and those two other Brazilian and Jamaican colleagues to teach our palliative care division, to teach our residents, to teach all throughout the Harvard system. And to me, that was the privilege of a lifetime to be able to really show them off and say it's the wisdom that we have here that can really benefit our communities in Boston as well. So we're so fortunate, and I hope that comes through.
It does. It does. Dr. Stoltenberg, another question for you related to access to opioids. And it was just really heartbreaking to think about anyone suffering, but certainly these young children suffering without access to just basic care. And the question is, are you partnering with developing country governments and pharmaceutical companies to improve access? And what are other ways, in addition to the education and related to clinical work, that can help solve some of these problems?
Yeah, that's a great question. So since it's now the 10-year anniversary of the declaration when the WHO named that this needs to be a mandate, that there has to be access to basic palliative care all over the world, there have been a lot of folks working on it, but just now over the past year, there's a working group that's meeting every 6 months. I've been honored to be a part of that working group. So there are a lot of people in that group specifically focusing on this. So I think what we know is, to start, there are absolutely changes in policy that have to occur. And working with the INCB, or the International Narcotics Control Board, together with ministries, there are, again, guided ways that leaders from that WHO working group have helped in other countries, that there are step-by-step tasks that can be done, that in a matter of 1 to 2 years, you can steadily start to increase the access. And that never can go without also education and training, so folks know the right patient populations where this is needed and beneficial, the patient populations where the evidence isn't as strong, and things like chronic pain that we need to make sure we're being careful, and also making sure that accessibility is safe. So we do have those evidence-based ways. There are people working on it. A lot of it, the initial steps for the countries where there's no availability, is really at the governmental level and international level. But then very quickly after that comes in the training and the education, where we are directly partnering with people in a lot of different corners of the world to make sure that there's adequate training so people can be prescribing safely and effectively for the patients that need it.
Clearly, many opportunities for advocacy. VR, here's a question for you. Could you say a little bit more about the role of the family as caregivers? How do you think about their strengths in that space, and what are needs of those caregivers that might be overlooked?
Yeah, one thing I love about this work is that it sort of was always surprising to hear about how family caregivers saw their role, or the strengths they had, or how they really were creative in piecing together the care that each patient needed. So in some ways, it's a very nuanced response. And I think our Wowokias often never knew what they would encounter when they walked into someone's home. That's such a sacred space to be invited into. I think in general, the communities that we worked with wanted to be surrounded by loved ones, and wanted to be able to engage in healing practices that couldn't be done in isolation, and often couldn't be done in a hospital room where there was a visitor policy of 1 or 2 visitors, that just wasn't culturally congruent. And so I think that enabling and offering, often having these very busy, taxed family members hosting gatherings or hosting community members, allowing people to come in and say what was meaningful about this loved one, and really provide them with respect and dignity as they were approaching end of life, is a huge benefit. I think there also was a lot of challenges. It's a very isolating role for these caregivers. So our Wowokias learned very quickly early on to schedule a meeting with the patient in the home, which often would involve many, many generations coming together and was a raucous affair. And then they often would schedule a separate meeting with whoever was identified as the primary caregiver, really to just provide support for that person, because it can be such a an isolating role. It's an honor in many of these communities to do this. And also it's really hard to do this when resources are limited or when you're trying to drive your loved one 6 hours across the state in a snowstorm so that they can get the medications that they need. And so I think there's a lot of overlooked needs. I'm glad that you highlighted it. And I think the programs that we are hoping to continue to be able to further certainly hinge around a Wowokia-like model, but also a way to really wrap care around these caregivers, to really see it as a dyad in a way that I haven't experienced necessarily in other communities, that these family members are going through this illness together.
I think that's so, so powerful. I think I always say we all, in palliative care, we all have to be in the deep end of the pool together. And how do we support one another? And that the caregivers are so, the wellness of the patient only does as well as their wellness of their caregivers. And how do we have ways that we really support them in that? Carol, I just wonder, are there any other, when you think about your caregiving journey, which you've had as well, are there other thoughts you have about as a system, how we should be thinking about supporting those needs?
I think that all that BR and Mark and Pedro have said is so true. And curiosity and providing caregivers with some agency. So often one feels helpless in a big system and a big hospital facing, pain and suffering in a way that one doesn't quite understand. And often the information is given in a hierarchical way. And a huge difference in that I found in palliative care is this way of asking questions, of being curious, of giving the family caregivers support and really agency in what's important to you. What do you know about your whoever it is you're caring for? And it's transformational. And I think it's, for me, something that is so special that it isn't just, what you do isn't just for palliative care physicians, that you have spread out to all the other, as many disciplines as you can, because it's like being a special ed teacher. Like, it's not just about knowing what to do with a child who's different or neurodivergent. It's really good education for all. And I think that the values and the mission that you have in palliative care is something that really benefits all.
Thank you. I think those are wise words, Carol. Thank you. So I think we're just getting to a point where it probably makes sense for us to wrap up, and want to thank everybody for their questions and patience for those if there are questions that we didn't get to. I would just really like to thank Carol so much for her partnership in this work, and really helping facilitate it and getting to understand it. And we're just incredibly grateful for that, Carol. And then, and yeah, a hug, little hug, virtual hug, exactly. And BR and Mark and Pedro, your leadership in these programs has really been just breathtaking to watch. Like, where this program is now compared to where it was 5 years ago or 10 years ago is really just amazing. And it's really a tribute to your leadership and collaboration, and just really putting your heart and soul and spirit into this work. And so incredibly grateful for all that you do, and really hope to see this continue to expand and to continue. So thank you. And thank you to everybody who joined us this evening. And if there are ways that you'd like to think about being more engaged in this work, please do reach out. We would be delighted to think about ways we might be able to collaborate. Thank you, everybody. Have a great evening.